Digital Health Week. For your information, Digital Health Week is a global movement where CSO, government, and then private company and health institution come together to champion digital health to universal health coverage. As we know, we need for digital health education in the public health sector is inevitable. The potential of digital technology in public health area is enormous, and to take full advantage of this technology, public health needs to have a basic understanding of how and why we work and how to encompass relevant technology and how to identify the necessary level of competency required and also how to address the ethic and potential pitfall for each technology. This webinar will also discuss about digital health curriculum between countries, online education, and how to implement digital health curriculum in public health school, and also discuss about the challenges and also discuss about the obstacle in curriculum implementation. So in this evening, it's an honor to me to introduce and welcome our speakers, the chairperson of Indonesia Association of Public Health School, and she is also the president of Asia Pacific Academic Consortium of Public Health, Ibu Dr. Agustin Kusumayati, MSc, PhD. Good evening, Ibu.
Good evening, everyone.
Yeah, and also it's an honor to me to introduce Professor Fernanda B. Gracias, GR PhD, as a Dean of College of Public Health, University of the Philippines, Manila. Good evening.
Good evening. Good evening from Manila, Philippines.
Good evening. And also I would like to say hello to Prof. Elahi Nezami as a Professor and Dean of Graduate at Degree Program Miller School of Medicine, Miami University. Good evening, Prof.
Good evening.
It's morning. It's morning in Miami.
Good morning.
Well, good evening to my colleagues in Jakarta, and it's a pleasure to be here.
Okay, good morning, Prof. Eli. And also, I also want to say hello to Assistant Professor Dr. Pit Chipong as a Deputy Dean of the Faculty of Public Health, Mahidol University.
Sawadee krap. Good evening. It's a pleasure to be here too.
Sawadee krap. And also, I would like to say hello to Bapak Febi Dwi Rahmadi, SKM MSc PhD, as a lecturer of in Global Health School of Medicine and Dentistry, Griffith University, Queensland, Australia.
Hello, how are you?
How are you?
Cool. It's 9:30 p.m. here in Brisbane.
Okay, thank you very much for your time to all speakers, and also I want to say thank you for all participants. We have how many participants right now? We have 154 participants right now, and maybe after 30 or 1 hour, the participant will be increased because in Jakarta still 6:30 and it's still time for praying. Maybe some of the participants will be joined soon. So before we start our agenda, I would like to inform you about the rules about this webinar. If you want to have some question in every session, please do not hesitate to write your question in question box, and please do not write the question in the chat box because we cannot see your question. So if you want to ask directly to our speaker, please raise your hand and we will promote you as a panelist so you can open your camera and then talk directly to our speakers. So, ladies and gentlemen, please let's begin to our first session. In the first session, we will focus on digital health education. It's very interesting issue, interesting something that we need to discuss more. And I think 2 hours is not enough to discuss about this. But let's begin this session. I would like to invite the first speaker, Professor Fernanda B. Gracias, GR PhD, and he will be talk about the curriculum of Bachelor of Science in Public Health program in the University of the Philippines, Manila. You have 15 minutes to present your presentation. Prof. Jun, the floor is yours.
Thank you, Lovery. I'll just share my screen. Can you see it?
Yeah,
Yes,
sure.
yes.
Okay, thank you. Okay, so magandang gabi. Good evening to everyone. Of course, recognition and thank you for the invitation to speak here. Thank you to the Indonesian Association of Public Health Schools, chaired by Dr. Agustin Kusumayati, of course, in collaboration with the Transform Health Indonesia. Thank you to our colleagues, to the public health educators who are in this attendance. Thank you and magandang gabi. So I'll be discussing to you briefly the digital health content in the curriculum of our Bachelor of Science in Public Health, BSPH program here at the College of Public Health, University of the Philippines, Manila. So for my wait. Okay. So for my talk, I have put here the outline. I'll be discussing to you briefly the areas of digital health. Then I'll be moving in focus to the BS Public Health program of the College of Public Health, University of the Philippines, Manila. And then I'll provide some reflections or insights on the integration of the digital health content in our curriculum. So although there is not yet a universal or formal definition of the digital health, acceptable criteria, including those of the provided by the Food and Drug Administration or FDA, actually covers some areas such as health information technology. They also discuss about wearable devices, telehealth, telemedicine, personalized medicine, and general wellness. So despite the fact that a number of these topics have been discussed in the medical communities for more than decades, the widespread use of mobile technology and internet has actually helped that these topics advance swiftly into practical applications. So other areas, aside from using digital health to reach the patient care and the community care, include the aspects of data use, the use of data, and the issue of prescribing software as medical care. So taking these definitions and positions into account, I'm sharing to you this table coming from Angs et al. That actually encompasses the areas of digital health that health educators will likely focus on in relation to clinical training their learners will undergo. So here you can see here the 5 topics: mobile medical applications and the corresponding descriptions, digital therapeutics, telehealth, wearable devices, sensors, digital biomarkers. In this slide, this actually coming from that document, from that publication also. This table actually summarizes, it provides a summary of an in-depth examination of the digital health education options in 2009. The document was published in 2020, so I believe this is an in-depth look of the digital health education in 2009. And I would like just to highlight, I will not go into details, that majority of the institutions or the programs that have been examined in 2019 have no formal integration of digital health in the curriculum. So you have that list of institutions and programs. So that's also coming from the same manuscript. Okay. So I'll now moving now to what we do now in the University of the Philippines, and discuss to you our Bachelor of Science in Public Health curriculum. So the University of the Philippines, Manila is actually one of the 8 constituent universities in the University of the Philippines system. So UP Manila is considered as the health science campus. So we have all the degree granting that includes medicine and other allied medical professions. And we also have non-degree granting units like the Philippine General Hospital, being the largest modern tertiary state-owned hospital in the country, and we also have the National Institutes of Health. So the College of Public Health is actually one of the colleges, degree granting unit of UP Manila, and the college actually functions as the Southeast Asian Minister of Education Organization, or SIMEO, TROPMED Regional Center for Public Health, for Hospital Administration, Environmental, and Occupational Health. Being the SIMEO TROPMED, no, it caters students from SIMEO member countries like Indonesia, Malaysia, Thailand, Cambodia, and other Asian countries. We actually receive also some students coming from Western Pacific countries and African countries, as well as United States, who are doing their field practice of their Master of Public Health here in the country. And the other one, we are also a member of the Asia Pacific Academic Consortium for Public Health. We just hosted last month the 53rd APAC PH. I'm sure Dr. Agustin had enjoyed last month the hosting of the college. The UP College of Public Health has also been designated as the country office of the Asian Health Literacy Association, or the ALA. So ALA actually promotes health literacy as an effective way to improve healthcare quality and reducing health disparities between communities, groups, and nations. And of course, we are also the regional hub, no, for the Western Pacific region for SISTAC, or the Systems Thinking Accelerator. So the SISTAC is a global community of practice for systems thinking, researchers, policymakers, implementers to engage and connect and collaborate to improve health and well-being. So this SISTAC is actually supported and funded by the World Health Organization Alliance for Health Policy and Systems Research. I'm just giving you an introduction of our college. So the college was established in February 1927 to be the to serve as a training ground for medical officers of the Philippine Health Service. Now we have that as the Minister or the Department of Health. So we have 7 departments in the college that work synergistically to fulfill the mandate of the college as the national and the regional center for public health. So we have the Department of Epidemiology and Biostatistics, we have the Department of Environmental and Occupational Health, Department of Health Policy and Administration, Health Promotion and Education, Medical Microbiology, Nutrition, and Parasitology. And we also have that list of academic programs. We have the Bachelor of Science in Public Health, our lone undergrad course, and we have the graduate level courses or programs. We have the Master of Public Health, and it has a TROPMED tracking. We have the Master of Hospital Administration, Occupational Health, Master of Arts in Health Policy, Epidemiology, Master of Science in Public Health, MSPH, with the following tracking by statistics, environmental, medical, microbiology, nutrition, and parasitology. And we have the Doctor of Public Health. So our discussion now will focus on the Bachelor of Science in Public Health. So the BS Public Health, or BSPH course, is actually a unique program that's designed to provide undergraduate students with the academic and the practical training and basic sciences in the field of science relevant to public health, such as microbiology, parasitology, environmental health, nutrition, public health administration, health promotion and education, biostatistics, and epidemiology. So outside the PH, public health outside the classroom or college, we also have the field practice, the development of the IEC materials, mobile app for hypertension control. And the BSPH students actually perform both the laboratory, research, and community health practice. So these are some of the program outcomes implementing collaborative researches, designing or implementing health promotion education strategies, perform appropriate laboratory tests for certain public health issues, identifying the patterns and trends based on appropriate assessment and laboratory tests. The others is assist in the management of healthcare organization and service effective in multidisciplinary and multicultural setting, demonstrate professional, social, ethical standards of behavior for professional collaboration endeavors. And the other is related to us being Filipino and the use of Filipino in English as a communication skills, promoting or simplifying positive Filipino values. And the last one is engaging and lifelong learning and understanding the need to keep abreast of the development of public health practice, and that includes the health, the digital health. So just to summarize to you the curriculum of our course, so it's a 4 years course. The first 3 semesters, they take their courses at the College of Arts and Sciences. But of course, it includes major public health courses during the first year. And the succeeding years their courses will all be taken at the College of Public Health. So with the revised BSPH curriculum, we have inclusion of new major core courses. And actually, the BSP Public Health has 2 tracks for our case. We have the population health and what we call the medical laboratory science. So I'll discuss to you the population track. So it's actually a discipline that deals with the health outcomes of a group of individuals, including distribution of such outcomes within the group. And it includes the definition, the measurement of health outcomes, the patterns of health determinants, equity and policy and interventions that influence optimal balance of identified determinants. And these are the courses, the prescribed and the elective under our population health track. The other tracking of our Bachelor of Science is the medical laboratory science track. So for this track, it's actually providing students with the opportunity to enroll in elective courses under the professional discipline of nutrition, medical microbiology, medical parasitology, and entomology, prepare the students to perform relevant clinical laboratory tasks in the highest quality, eligibility to take the medical technology, medtech licensure examinations, wherein students who have taken at least 24 units of medical microbiology courses under this track are actually eligible to take this licensure examination for the registered microbiologists, and opportunity for students to work in the different laboratories outside the community or the population. And these are some of the medical laboratories, the courses prescribed and the elective. So our BSPH graduate entry rules, they could become a health program implementer, leader, manager, researchers, teachers, educators, health educator, health associate, laboratory scientist, and for our population health track, maybe community health organizers. Of course, with the common goal to prevent and promote health of the community or of the people. So what are the courses with digital health content? So we have this science, technology, and society course. It's actually an interdisciplinary general education course that examines the past, the present, and the future of science and technology in the society, looking at the factors that affect the development of science and technology, with emphasis, of course, in the Philippine setting. And it uses local and practical examples to analyze and illustrate the dynamics between the science and the technology and the society. And usually it's being taken during the junior or science level. So the science, technology, and society has actually 7 modules looking at history and relationship of science and technology and culture, philosophy of the science, cultural aspect of the science and technology, the dynamics of the science, technology, and society, the policy and the development, group case studies and presentations, and of course, the last one is their output, which is the final pitch. What is this final pitch about? The final pitch, it's actually an individual. It's an individual work. And what they do here is they actually come up with some projects or ideas, innovative ideas, wherein they will apply or in relation to the digital health. This is an example of the output in this course, wherein there is this nurse, your nursing course virtual guide. So this one is actually produced by nursing students, but we can actually come up with our own projects that looks at the public health. As you all know, we also have, so if you have the telemedicine, if you have the telenursing, we also have this telepublic health that ensures health beyond borders. So this telepublic health is actually the use of telecommunications techniques that implemented over a distance for the purpose of sharing the public health expertise for the benefit of policy makers and service providers, and providing health education for the public. The telepublic health, it's actually, you can come up with a project like this one, especially during the time of COVID-19 pandemic. So the definition of telepublic health is significantly actually differs from a close similar term, which is the telehealth, which actually defined by the International Organization for Standard as the use of telecommunications techniques for the purpose of providing telemedicine, medical education, and health education over the distance. So the elements of telepublic health have actually been seen in the past to assist health officials and the epidemic-stricken areas to actually manage the contact tracing, the mapping of disease clusters, in an area that is dubbed as tele-epidemiology. So now, as the new normal actually redefines the way essential public health functions are being carried out, there is actually a need to reimagine how telepublic health approach can be applied in other fields within public health and many jurisdictions at once, that actually transcends borders that are heavily guarded due to the still implemented quarantines and lockdowns. The other, throughout the course of the BS Public Health students, they are also being encouraged and sometimes required to attend seminars, webinars, and lecture series on the use and importance of digital technologies in public health. So this one we also encourage students to attend seminars, webinars, and lecture series like this one. So the other courses wherein there is a partial or digital health discussions, we have the PH Introduction to Public Health, the PH2 Introduction to Global Health, Health Promotion, the Strategies in Health Promotion, Disaster Risk Reduction Management, Health Service Management, Health Sector, the Public Health Practice 1 and 2, and of course when the students do their special studies and research. And moving on to my last part of my speak is some reflections. So the digital health's practical implication to patients and community care will actually compel the health science programs, maybe the committee, the program committee, and the academic clusters to really determine the most effective way to deliver the topic on digital health to their students. So educators now have actually the duty of staying current on current trends in the digital health advances as these technology developments are anticipated to dramatically rise and expand their impact in the health curve. So the other one, of course, schools and programs of public health need to actually reshape their curricula to better reflect the evolution of the field and meet emerging public health challenges. There is a need to actually a need for the skills and competencies of public health graduates to actually match the task and addressing the population's health needs. Even if there are many chances, there may not be many opportunities actually for faculty development and expert to support learning experiences. And since it will be challenging to incorporate digital health topics in the curriculum, many institutions, many academic institutions may actually decide to provide interested students with tracks, with certifications, or even adjunct degrees. I will share with you this one. So this one it's actually the digital health training options that's available. So it could be the integration could be built into the curriculum, wherein the digital health materials provided throughout the curriculum and included in the didactic classes, in the laboratory exercises and experiential education. The other one, it could be like what we have also is it's integrated in some of the elective processes, no? And the other one is maybe coming up with adjunct degrees, no? So for the UP College of Public Health Bachelor of Science Public Health program, what I can actually say is that there is actually no formal integration into the curriculum as didactic teaching. And there are somehow limited courses that are built in to the BSPH curriculum, and that digital health content is more on elective on this elective track processes. As a complement, the students are actually introduced to digital health by actually encouraging, or what I said, requiring them to attend seminars, webinars, and lectures on the use and the importance of digital technologies in public health. And to end my my lecture, I would like to use this one coming from Sandro and Lisa, wherein they tell that schools of public health, like the UP College of Public Health, should prepare the public health workforce of the future, ensuring that they are equipped both to handle the public health challenge of today and to adapt to the public health challenges of the coming decades. And that includes also the digital health. I think that ends my brief presentation, and I would be happy to respond or engage in the discussion in a while. Thank you.
Thank you very much, Dr. Jun. I will remember your last speech. School of Public Health should prepare the public health work in the future. Yeah, so we need to adapt in the future. I think it's not in the future, now and future. Yeah. Thank you so much for your remarkable speech. We still have time for the second speakers. The second speakers, of course, some people. We already know her. She is very famous in Indonesia, especially the Faculty of Public Health around Indonesia. Ibu Agustin Kusumayati, MSc PhD. She is the chairperson of Indonesia Public Health Higher Education Network, and she is also the president of APEC, and she will present the digital health content in new Indonesia standard core curriculum of Bachelor of Science in Public Health program. We already hear about Philippine program, and we will hear about Indonesian. The floor is yours, Ibu.
Thank you, Ibu Lofi. Very good evening, good afternoon, everyone. So it's really nice to meet all of you in this very nice situation. So since we have COVID-19 pandemic, the last time we getting used to use the information and communication technology so that we can meet from all over the world by using this technology. So I want in this moment now, I want to share what are the digital health content in our new Indonesian standard core curriculum for Bachelor of Science in Public Health programs. So I will cover several topics in my presentation. Sorry. Before first, of course, we let us see the impact of the fourth industrial revolution on public health, and then the application of e-health, and then the e-public health. What are the opportunities for future development? And then last, the digital health content in our national core curriculum. So first, let's see the impact of the fourth industrial revolution. So industrial revolution give new technology and then new advances in life sciences. So it is easier for us to understand many problems in health, in human health, and then we can understand better about many illnesses. So in this case, we can have a better diagnosis and also better treatment. So the public health professionals should respond to this situation by applying new technology and advances in life sciences in developing promotive and preventive measures. The second, the information and communication technology also allow us for large leaps forward in medical research. And this lead to substantial changes to healthcare. So in this case, also public health professionals should adjust their promotive and preventive actions towards changes in healthcare. The third phenomena, the new technology could disrupt the existing relationship between the providers and the healthcare providers and the stakeholders, including also the community, the population. So in this case, we as public health professionals need to redefine our position in the relationship between all healthcare providers with our clients. And then universal connectivity and greater access to information also empower people, empower the community. So in this case, we have to consider and respect the new position, the new condition of our community in developing our promotive and preventive interventions. Last but not least, the new technology also will improve the way we can monitor the health of the patient, applying personalized treatment plans and predictive medicine. So it is also the challenge of us as public health professionals to develop individually personalized promotive and preventive measures. So those are the effect of or the impact of the fourth industrial revolution to public health. Now let's see the application of e-health. There are already application of e-health. For example, we have mobile health. So many of us now use what we call as a smartwatch, where the watch can also monitor our heart rate, our blood pressure, our oxygen saturation, etc. So that's a kind of health monitoring that we can do by using a mobile appliance. In the other application of e-health is, of course, telemedicine and telehealth. Electronic medical records, electronic health records, also another application of e-health. But there are many areas that are not developed compared to this the other three. The first one is how we can also use e-health to develop virtual healthcare teams, to utilize ICT in manage the health knowledge, and also to provide consumer health or develop consumer health informatics. So these are some examples of the implementation of e-health. electronic health records, we know already, clinical decision support system. So the ICT can help to doctors to make decision about a condition of a patient. This is a very advanced use of the technology. Telemedicine, we all experience about this telemedicine, especially during the previous pandemic, where the mobility and contact between people are really restricted. E-health also can be used to deliver health informations, not only to the community, but also to professionals and other stakeholders. Using IT and e-commerce, for example, we also can improve public health services. For example, by conducting education and training of health workers. Applying e-commerce and e-business also can improve health system management, for example, in terms of planning, budgeting, accounting, and other management activities. mHealth, we already we already use actually the wearables that are now getting very popular, that many people use the wearables to control his or her health condition. So how about the public health? There are many opportunities for us to improve by using the advancement in information and communication technology. First, we can utilize the technology to improve health security. We can also develop better prevention people about the leading causes of illness, injury, disability, and death. We can strengthen also collaboration between public health and healthcare. This is usually many issues raised about the collaboration between public health and healthcare. And then we can also put data and information into the right hands of public health decision makers at the right time, the right place to take action. These are the strategic direction of e-public health. So e-public health really develop us in dealing with data. We can use the technology, the ICT, in data collection. For example, we can use the handheld devices, automated information messaging. We can use different data management application to collect, to aggregate, and to report routine data. We can use also the ICT for data management and storage. For example, to address requirements of interoperability and integrated sets of data. We can apply more sophisticated data storage to address complexity and variability of health data across the health enterprises. And then we can improve relational databases. Yeah, we can increase the norm of the relational databases. Still dealing with data, we can use also the ICT for data analysis, for presentation, and also for the use of data. We can utilize the technology in extracting and triangulating of health data, data analysis, synthesis, develop dashboard, etc. And of course, using the advancement of ICT, we can improve also the quality of the data so that we can make decision, we can develop intervention more accurately because we have a better data quality. So there are opportunities in developing health informatics. For example, now we are leaving manual reporting from traditional data sources to automated data use and analysis from novel sources. We can improve interoperability. We can also have more novel partnership and collaborations to overcome many problems based on strong health informatics. And then using advancement in ICT, we can also make a better analytics, better visualization and communications of the health data, and give better information to our stakeholders. And of course, this good information may lead us to better fulfilling of the essential public health services. These are some opportunity in surveillance, for example, how ICT can enhance the accountability, the resource use, the workforce, and innovation in surveillance. It can also accelerate the utilization of emerging tools and approach, yeah, to improve availability, quality, and timeliness of the data. And then, of course, through cross-cutting agency initiative, surveillance can be improved so that we can improve also the quality of public health measures. Now, me come to the last part of my presentation, that is about the digital health content in our national standard core curriculum for Bachelor of Science in Public Health programs. So I mentioned here some content that already included in the new curriculum, in the new standard curriculum, relating with digital health. For example, about the concept of digital health, the types of digital health technology, the role of social media in public health, data sources for digital health, international data standard, the use of various forms of digital health technology. We also input in our new curriculum the content about utilization of digital health in public health, technology adoption and implementation, analysis and utilization of big data in public health, digital health interventions, critical review in digital health utilization in public health measures, and utilization of machine learning in public health. So these are some examples, for example, about the concept of digital health. We cover content, for example, history of digital health, the value and importance of basic digital health services, emerging digital health technologies, digital health improve data sharing while maintaining patient privacy and confidentiality, and then how digital health technology requires rigorous standards. About the various forms of digital health, we introduce to our students these various forms of digital health. For example, social media, forums and message boards, review and opinion sites, blogging and microblogging, smartphones, bookmarking and media sharing, and hospital information system, as well as also public health information system. This is about the various forms of digital health. About the role of social media, we put enough attention on social media because society like in Indonesia is very much influenced by the content of the social media. So we actually can use social media in public health, for example, to inform, to educate and empower the people about health, to enhance the speed at which communication is sent by social media, mobilize community partnership and actions, facilitate behavior change, collect surveillance data, and also we can understand better public perceptions on various health issues. So there will be quite a strong content relating with social media. We also cover issues on data sources for digital health. For example, the electronic health records, surveys, administrative and medical records, claims data, vital records, surveillance, disease registries, and of course, peer review literature. So we introduce these sources of data to the students so that they can understand what kind of data they can access and they can use to develop a certain intervention or a certain measures by using information and communication technology. Application of various digital health technologies, for example, mobile appliances, wearable technologies, health information system, telehealth and telemedicine, artificial intelligence, machine learning. This is something that's very fashionable, the machine learning, how machine learning can help us to develop a certain behavior that we want to our community to have. This can be what can be designed by using machine learning, gamification, behavioral sciences, and of course, big data. Big data is very interesting, and then many people now using big data, especially during the COVID-19 pandemic. We use big data for various sources to make prediction of the condition of COVID-19 in Indonesia.
Do you have 2 minutes left?
Yeah. Health technology transformation. This is the very important content also. Priority of health technology transformation, health data integration and development, health application development and integration, health technologies ecosystem strengthening, and also digital transformation governance. This is very important because without the good governance, we will not be able to utilize digital health for the best of the community concern. I think this is all what I can share. So we are all in the forefront of ensuring the world's sustainability during this disruptive era. So thank you so much. So I return back the floor to Ms. Loveria. Thank you.
All right, thank you, Ibu Agustin Kusmayati, for your speech. Yeah, we will learn so many things, and I think we have one question for you, but later we still have one more speakers. I also honored to invite the third speaker, Prof. Elahi Nezami. She is from Miller School of Medicine, Department of Public Health Science, Miami University. She will talk about the online MPH program. The previous one we talk about the bachelor degree, but now we talk about MPH program, specific and service need for successful launch of online education. The floor is yours, Prof. Eli.
I thank you, Professor Augustine, for inviting me. Thank you for the organizers of this webinar and bringing attention to such an important topic for the welfare of our public in different regions of the world. I don't know if you would be able to share either give me ability to share, or if you can provide the slides then. Yes, perfect. Is that showing for everyone? I don't know if. Do you see my screen?
Not yet.
I have shared my screen, but I have also provided the slides. So if our host would be able to show the slides, that would be highly appreciated.
Bisa dari kita aja?
Yes, I will trying to share the screen. Yes.
And while that is being done, I want to tell you that while my presentation is going to be, yes, you have it. Perfect. Now we just needed to have it in a presentation format. Wonderful. I really appreciate your assistance with this. We can go to the next one. So my focus is on the MPH education. However, I would be happy to answer questions or talk about the bachelor's degree as well. I just transitioned from this year from University of Southern California to University of Miami. And at the University of Southern California, I developed and directed the undergraduate education in health promotion and disease prevention, which is a public health undergraduate program for over 25 years. So happy to answer those questions as well. But I want to tell you about what is happening with the world of Masters of Public Health Education in United States. Post-COVID, there has been a very large increase in the students' interest to seek MPH degree. If you see In 2019 to 2020, there was a 23rd increase in the number of applications. We have a central application system called SOFAS, where all the students who want to go to study the degree of MPH apply through this portal. So we can basically have a good tap of how the number of applicants and interested students in the area increases or decreases. And we saw that this trend continued. So over 24,000 students applied to enter to MPH programs. Next one. Now, why is that? Well, partially it was because of COVID-19 and the fact that the discussions about role of public health was discussion at every home. There were ideas of what public health is, why public health is important, what are the jobs in public health. And with opening of new jobs, there were a lot more applicants who were interested in the degree. So this is from the US Department of Labor and Statistics that I'm sharing with you. And what they project is that until for the next almost decade, there are going to be increases in all areas that require public health. So this was another reason for the increase in the number of students who sought and are continuing to seek degrees in public health. Now, I'm talking about mostly MPH, but that is true about the undergraduate degree, doctorate degree, and other relevant degrees to public health. Next one, please. So this also coincided with creation of more formal tracks within the areas of public health. As you see, the number of universities and programs that are offering a generalist MPH is now a minority when you look at the top 20 MPH programs in the country. But there are many formal tracks that have been created, while the traditional tracks were like epidemiology, biostatistics, policy, environmental health. Now there are many new innovative tracks that have been launched and are successful in attracting students. Next one, please. Now, you will see I'm now going and transitioning to what is happening with the online MPH program. Now, online MPH program, the way I am going to address it at this presentation is the entire degree is delivered through online education. So the student can register for an online MPH, complete their online MPH, graduate with that degree, and has never set foot on the campus. Now, there are some programs that have some immersion training, and the students may visit once or twice the campus at designated times, but there are many programs that for the entire delivery of the program, the students will not come to the campus. And that is the focus of my presentation today, because as we see in the United States, with the large number of applicants who are interested in different varieties of public health education, the online education is really booming. It gives convenience to the students. It gives the opportunity for students who are full-time workers and cannot afford to come to campus to be able to get their degree. It allows students who have families and during daytime they need to attend to their requirements of their family, are able to take these classes in the evenings, on weekends, at their liberty. And as you see, there are about almost 50% of the universities that in the United States, the programs are online. Some of them have both online delivery as well as residential delivery, which is the way we used to be accustomed, where the students and the faculty go to the university to do the business of teaching and learning. But now almost 50% are entirely delivered online. There are two kinds of delivery of online education, synchronous and asynchronous. With the format of synchronous, you would have class time, you would have office hours, you have lectures and opportunities that everyone goes to the class at the same time, of course, digitally. And there are interactions that happens at the same time, and it's virtual. However, there are programs where everything is videotaped or audio taped. Therefore, you can get your degree in asynchronous format. You would be able to go to your computer and start your class at 2 o'clock in the morning or at 7 o'clock in the evening. It is entirely at your liberty, and it will allow a convenience that the regular residential programs cannot provide. Next one, please. So here I have the top 20 ranked university public health programs in the United States. And you see that majority have online MPH program. The ones that it shows currently don't have online education. I can tell you that several of them already hired someone to become director of online education, and they are in the process of completing their online MPH. The reason it doesn't show here is that they are not accredited yet, but you will soon see that all of the top 20 ranked MPH programs in the United States will have online delivery. Of course, there is one that has not still done that, but that would be a discussion for later. Next one, please. So now I want to talk about looking at different degrees and whether they have online delivery format or not yet. And I'm benchmarking my state, the universities that are in my state, because if I include the entire country, it would be impossible to really see what's happening. And I'm comparing those with Johns Hopkins, that is the #1 public health in the United States. It is the first university that launched online MPH education, and it has potentially the most exciting types of programs that many universities in the United States look at benchmarking what they are doing in creativity against Johns Hopkins University. So I am showing you that, as you see, the purple is online MPH. And if you look at all online graduate certificates, it's showing up in orange. However, at this time, they do not have a bachelor's degree launched online. But you see that the dark blue, that is the online bachelor's degree programs, show up in other universities. So there are many programs in the United States that have started working and creating online bachelor's degree program. But I want to preface that the reason for having more online MPH programs that are offered through online education is that in the United States, we have two different kinds of bachelor's degree in public health. One area, one kind of degree prepares graduates to enter workforce. But the other kinds of bachelor's degrees in public health really are more of a pre-health introduction for students who are interested to go to medical school, pharmacy school, dental school. And the program that I developed at the University of Southern California about 26 or 7 years ago was more of the kind that would prepare graduates to enter for further education for professional degree programs, although we then started having 4+1 degrees that allowed our students to have entrance to the MPH program, and through getting their MPH, enter the workforce. There is also a new trend that we do have both undergraduate students with undergraduate degree in public health, as well as masters of public health that enter the workforce in the area of public health within the United States. But there are many students who have a preference for, and many employers who have a preference that the students get their MPH degree as well. So that is basically a snapshot of how online education is happening in the United States, but there is great excitement, great enthusiasm to have online education programs, which has got expedited post-COVID. When we delivered our courses online, it created an excitement for students who now are asking and seeking for convenience of being able to get didactics through online. There is an interest for hybrid education, where in particular for undergraduate students, they want to go to campus, they want to have the experience of being in person in classes and have that experience, but at the same time, they're asking for convenience of online. So they're asking for possibilities of hybrid education, which many of the universities are looking into. The integration of digital technology in education has been inevitable for us. It is something that we are blending technology into our classes in person as well. And it has become more of an expectation that we utilize that in our in-person classes. Now, I want to, in the next slide, share with you, well, if you want to go to online education, what are the requirements? Because online education is very different than teaching on Zoom or speaking to a camera. It's very different from the styles of our teaching in person, where you would have the opportunity to see your students, to engage your students. And there are many things that we can do in person that at the beginning, when you look at online education, they become intimidating. However, there are solutions for all of them. And I want to share with you some of the requirements of how do you make an online education successful. May I have the next slide, please? Okay, so when we think about success, we need to consider, well, whose success are we looking at? And it is important to build success at every level because you want to make sure the institution is successful in delivery of an online education. You want to make sure the learning technology you're utilizing is successful. You want to make sure your faculty are successful as well as your learners. So if you look at what is required for the institution to be successful, you really need to have a high quality delivery of online education. You're no longer in person, so you want to make sure what you deliver is in line with the brand of your university. You have to assure that you are having marketing, recruitment, and retention of your students, because it is not successful for the institution if you start with 100 students and at the end you have 2 students because you were not able to retain them, which talks about what is the quality of delivery of online education. You need to have 24/7 tech support. If the students are going to reach to your platform to do their learning at 3 o'clock in the morning and it fails, you need to be able to call someone, reach someone and say, I'm trying to see this lecture, it doesn't work. So many programs have 24/7 tech support to be able to support the students' need. I'm still actually on, yes. Back, please. Am I? No, not faculty. I'm still, yes, perfect. I'm going to go fast. Probably I am short of time and that's why it's going fast. One of the very important things for success is that you have to make sure you have assessment integrity. You're not in the class to see who is taking the class or the exam. You're not in the class to see what are the materials that the students have access to. And every student, while they're taking the exam, can easily do Google searches and find anything and everything. So you need to have assurances of assessment integrity of who is taking the test and that your assessment is designed in a way that either people use technology that locks the computer, the learner's computer, so they can't access the Google searches, but they have liberty of using other devices. So we go through how do you design an exam that even if the student has access to everything, it would still keep the integrity of the assessment. And of course, you have to make sure your alumni are successful and get the jobs that they wanted to get. And the employers are happy with what they have learned. Next one, please. So next one. In regard to learning technology, you really need to assure that you have high quality and engaging content. If I cannot see my learners, I need to have engaging content that would get them to be absorbed so they don't put the camera off and go make tea while I'm lecturing, or do not call their friends and just have this going on. So you need to create a digital campus so the students can interact with each other and they feel that they are one with the faculty and with the staff. And they are able to have really the opportunities that they engage with each other. You will track their progress. So you wouldn't wait for the exams to know, have they done the reading? Have they watched the slides? Are they able to answer questions? And you want to make sure that you have secure networks in doing all of those to keep privacies. So you need to build a learning technology that is outcome driven. They are learning the competencies, and in the United States, we have an accreditation that requires 22 competencies for our MPH graduates. For undergraduate students, it's less, it's more informal and less tracked, but with MPH, we track it very carefully. Next one. You need to build success for your faculty. Most of the faculty are not trained to teach entirely online. When the first time I did it, I thought it's easy. It is not easy. It is something that needs to be very thoughtful. You need to develop the faculty on how to do online teaching. You need to have consultation for them and customize it depending on the faculty. Some of us are very fast in uptake of technology. Some of us are not. But you need to have a course strategy for each faculty, for each class, to say, what is it you want to deliver in this class? How are you going to assess at the end of each class that your students learned the content that you wanted to deliver? So we actually don't design the classes entirely with the faculty, but the faculty designs the content. Then we're going to have learning technologists that say, well, based on the adult learning models, how do we need to space your teaching? How do we use different models to be able to deliver this? And as you know, adults or most learners, for 5 minutes, they can pay attention if I just talk. But unless I integrate other things, that the attention is going to be distracted within online teaching. So, and we sit with an instructional designer that says, now do polls, now do integrate a video, now ask them to talk with each other. So there is quite a bit of skills and knowledge that has to come in creating success for the faculty. Next one is, how do you create success for your learners? Because your students have to learn the content. That's the only way you know you have been successful. So they need, again, 24/7 technology support. So they can call, they can send an email, and somebody would be able to check what is going on, that they cannot send a report, do their papers, or watch a video. It needs to be easily accessible to our students, and you need to assess whether students are happy. For our regular residential classes, it's at the end of the semester or middle of the semester that we do teaching evaluation. With online education, it is advisable to check in with the students more frequently to know, are they getting the material? Do they have questions? Are there things that should work better for them to understand the material? Do we have good systems of answering their questions? Because if the classes are entirely asynchronous, you can't raise your hand and say, I didn't get it. Yes, you can go backward and play the game to listen again. But if it is not, the concept is not still well understood by the students, there needs to be mechanisms that you ask them, what do we need to improve? And we improve throughout the semester. All of the classes, it's advisable to be mobile accessible. We have seen, it is not true that we have it at the moment for all classes, but that is the goal, and it's an aspiration, because we have seen our learners have a preference that they would be able to access all of our courses through their cell phones. And you need to have digital career counselors. You need to have people who will help the students to get internship, to do their capstone, to do practicum. But also after they graduate, we have now within the digital campus, digital career counselors who will help the students find jobs, refine their CVs, do interview practices, and get wisdom and guidance. Because I go back to the goal of, for all of the, from starting from institution to faculty to student, we call it success. If our students, after they get their degree, they find a good job, what they were looking for when they started the program with us, and the employers will be satisfied that they have all the competencies and they can perform their job to the best way possible. That's when you can say, I've had an online program that has been successful. And with that, I will stop. If there would be interest, I can tell you about how the technology of making the courses interesting is picking up, because we are really attuned to not losing attention span of our students. And in some modalities, there are even assessments that shows students are having preferences for delivery of programs that are entirely online. Our faculty are also reporting to us that utilizing the technology, they feel that the way they are teaching their courses in residential program has improved as well. And with that, I think that is my last slide. I will turn it to the forum. I would be excited to answer any questions that our attendees in the webinar may have. Thank you again for your time.
Thank you, Prof. Ali, for your informative presentation. So we already have 4 questions for this session, Prof. Ali, Prof. John, and Ibu Agustin. So I think I need to read all of the question. We have 4 questions. The first one is for Ibu Agustin from Siska Darmayanti. Could you share example about CST application at laboratory or clinic? Many thanks. Ibu.
What is actually CDS stand for?
Yes. Yeah. Bu Siska, would you like to open your mic? We will trying to promote you as a panelist.
Yeah, while waiting for the Ibu Siska to explain the what CDS is stand for, I would like to try to answer the question from Mr. Adi Saputra. Can I?
Yeah, sure.
Yeah, okay. Yeah, Mr. Adi Saputra, very good questions. Yeah. Actually, we already when developing the new standard or national core curriculum for BSPH program, the digital health already incorporated in the new standard. So besides, we do have quote unquote new courses that will cover some issues of digital health. But then the application of digital health in various aspects of public health will be applied and will be taught and also practiced in various courses. For example, in health promotions, health educations, we put the experience of the students to use social media and other ICT technology in developing health promotion and health education program, for example. So in research methodology and also in doing field work, students are trained to use ICT technology to collect data, to analyze data, to present data, etc. So we encourage that our students are not use anymore the written questionnaire to collect data. Instead, they can use ICT, the smartphone or other equipments to collect data, as well as later on they can manage the data. So, for example, in surveillance, we also ask the students, we give the students the experience to apply ICT in, let's say, developing surveillance system, etc. And of course, in those who choose biostatistics as their and health informatics as their major, will have more opportunity in working with digital health and ICT. So actually, the content of digital health will not only deliver to the student through one course, but it will be it will be covered in various courses, because we want to introduce the use of ICT in various public health functions, and also we want to give the competency to our students to really use and apply ICT in various public health functions. So that's my answer to Mr. Adi. Let me answer the question from Ms. Dwi Handayani. Very good questions, asking about the readiness of human resources and each region in Indonesia in facing the digital transformation of health, and what strategies need to be done for equitable distribution of digital health services in Indonesia. Yes, the situation in various regions of Indonesia are not similar. If we say in Java Island, for example, the internet facility and other facilities are quite good, but in non-Java islands, for example, in Kalimantan, Sulawesi, East Nusa Tenggara, West Nusa Tenggara, and also Maluku and Papua is quite much lower, the quality as well as the availability of the internet and also other infrastructure. So this is also another challenge for us to develop the human resources that have adequate or good digital health literacy. So what are the strategies? So we, as the Association of the Schools of Public Health, realize that the quality of schools of public health in all over Indonesia are not similar. The gap is actually quite big from the best one to the less developed one. So, but we already have the the commitment to bring all together the schools to develop together. So in this case, that's why we developed the standard core curriculum. And then now we are moving forward by developing the standard teaching material. We call it as buku ajar. And then it will be followed by training of the lecturers. So hopefully, with these steps that will be taken by the association, the readiness of the schools all over Indonesia will be improved. The problem is now how the readiness of the institutions, of the schools itself, because the condition of the schools are various, different. And if we see the presentation from Professor Ellie, how the situation in the school among the lecturers and as well as the students should be available to support adequate online learning, and then this can be a benchmark. If we want to introduce digital health literacy, we to some extent have to be able to have also those kind of requirements. So I understand that the conditions of the schools in Indonesia is not similar, but we have to try our best to improve the condition and then utilize whatever we have to build or to develop digital health literacy among our students. So that's what I can answer so far. Ibu Love, maybe you can move to other question, to other speakers maybe.
Okay, thank you, Ibu Agustin, for your answer. It's very comprehensive, yeah. And I think I need to hear about. I want to trying to read the question from Yosef El Lamordra. Maybe for Dr. Prof. Jun, or maybe Prof. Ellie, would you like to answer this question? Maybe about what about the data safety concern so far? Is there any specific regulation for sharing and process EHR anonymously? Would you like to answer, Prof. Jun or Prof. Ellie?
So I wouldn't be able to talk about data safety when it comes to medical records or the data that is part of the hospital system. However, we need to have the same level of safety and security for students, because you don't want anyone to access personal information about your students, about their grades, about their performance, any of those things. So data security, the system where all of the didactics as well as student evaluations are kept, are protected within our proprietary, there are some that are different platforms, but within the platform, there's high level of security that it is not something that anyone can access. So that is quite, it's one of the requirements for the Department of Education that we assure data safety. But that is something that it's within the IT and within the university, it is protected and safeguarded, but they are not accessible in any way. But only the professors and the administrators within our educational program. Any permission to release any of those information will require and has to follow the FERPA guidelines in the United States. The universities spend a lot of money to assure safeguards and creating walls that all these information are protected.
Okay, thank you. Prof. Jun?
Yes, I would like to add on that one. For this one, I don't know the context of this one, but let me just contextualize about the electronic health records. I think the question of Joseph, let's just situate it in a rural health unit and a barangay health unit, wherein the health records of the patients, no, then here we are our Bachelor of Science in Public Health students who are doing their field practice in that in those local government units. Then I think for us, we actually have this data privacy law, and our students are really instructed, and they are given some guidance on how to deal with handling health records of patients that they might encounter in the field. No? So that's part of the orientation. That's part of the lecture that has been given to them. That's all, Lovely. Thank you.
Okay. Thank you, Prof. Jun. I think we are running out of time. So we still have one question maybe from Ibu Irma Yunita. It's very interesting to have full online class for magister and doctoral program. I also want to have it in Indonesia. It's really impact of technology development is make a big opportunity for students to continue their study during full-time work. I also want to ask Prof. Ellie for the last question. You always say 24/7. Yeah, I think it's the key how you can maintain 24/7. Maybe it's related to Ibu Irma. Prof. Ellie, the last one question.
Okay, so it is actually a service provided that if you are providing an online education, any time of day and night, some of our programs have in person, you call and somebody will pick up the phone and says, what is your issue? What is and you can say, I cannot see the slides, or I don't have good audio, and they can actually link to your computer and fix it for you. So it's when we talk about accessibility, it means you could be a person who is taking care of 4 children and also is working full-time, and you can only take your MPH classes when everyone else is asleep and it's 2 o'clock in the morning. You should be able to access your learning, and if you run into any trouble, it's actually 24/7, 365, 24 hours a day, 7 days a week. every day of the year. But not that all programs have that, but there are many online programs that make it available to you to have that kind of accessibility anytime for asking for help.
Oh, wow. Okay, thank you so much, Prof. Ali, Prof. Jun, and Ibu Agustin. We still have a second session. We still have Professor Pit Chipong and also Bapak Febi. So we have to close the first session, but if someone wants to ask any other question, would you like to stay here and hear the presentation of the second session, and maybe some of participants want to ask some questions to all of you, is welcome to all participants to write on the question box. So we have to move to the second session. So we have Professor Dr. Pit Chipong. He is a Deputy Dean of the Faculty of Public Health, Mahidol University. Sorry if you have to wait for a long time. You will be present about the health information technology and application in Thailand in the new normal era, Child Protection Project, special case. Yeah, the floor is yours, Prof. Pit Chipong.
Okay, thank you very much. Let me share the slide. Okay, good evening. I believe most of you will be same time zone as us, except some from either USA or Europe, right? Which is different times. My topic will be slightly different. This is health information technology and application in Thailand in the new normal era. And our focus will be child protection projects. As many people mentioned, we have many technology applied for the health sector: wearable device, robotic, Internet of Things, augmented reality, cloud computing, and data analytics. Many subjects has been done in order to improve healthcare system and also try to improve the health situation, especially during the COVID. We can see that many this is my award, and I got many awards from international regarding the innovation. Anyway, this program is a Child Shield program in Thailand, and it's a lot of partnership. We got a funding support from UNICEF and also from Ministry of Public Health. We have partnership from University of Ford. They are funding a parenting for lifelong health, and we make all of this partnership to make it Child Shield. Why we need to have a Child Shield? This is an innovative surveillance system that basically use hospital information system. We get the data from hospital, like previous speaker say. We try to do health information exchange. We try to do a health data center. We do everything under the GDPR, General Data Regulation Protection, or HIPAA, Health Data Protection, and so on. We care about inform and consent form. We care about Personal Information Act. We need to do it, and we can do it. We use the data record from hospital for children at least variants using a predictive analytics and machine learning. We provide the monitor for the risk group. We divide children into 3 groups: normal, risk, and the victim. We monitor risk group, and we provide a parenting program for their parents and guardians. And we manage the victim group using the Primero program. This is another program provided by UNICEF. They are victim or case management. So we all combine this together to make a Child Shield. Why we doing this? Because we know that the violent cases are basically tip of the iceberg. There are just only few cases report. In Thai, they say that there are just only 9,000, but UNICEF predict that more than 470,000 cases are under report. And there are many cases that close to violence, like a child abuse. You should know that Thailand or many countries in Asia, their parents or their guardians, sometimes they use physical violence or they do verbal abuse to discipline their kids. So sometimes it's just a thin line between discipline, abusive, and violence, at least in Thai. So why we try to doing this? Because we don't want the kid to get the adverse childhood experience. Once the kid get this experience, they are least to have an early death. Many problems can occur if they have this AEC experience. For example, they have a poor diet, they have higher chance to smoke, sex under age of 16, get pregnancy, become teenage mom, and so on. So this is a reason why we need to avoid kids going into the AEC, and that's why we try to introduce the program that can help do proactive. I mean, you should know that the case, most of the case, they are passive. The staff will wait for the kid to show it at the hospital, and we don't want this to happen. And this is what I did present in the UNICEF at the ADB a few years ago. Why we're doing this? Because as you know that we have a lot of the paperwork. All the staff is quite busy doing paperwork, and it's difficult to do anything. We try to introduce technology. We try to introduce IT into the healthcare system, but many people make IT become burden. We have to do like a double system, the former one and the new one, and many times the system make the people become like even more frustrated because the new system and the old system database wouldn't operate and so on. Even we try to do, and as I just mentioned, we have a lot of cases under report. And because of the COVID-19, those cases need to do a lot of intensive and time consuming for the consulting. But because of the COVID-19, you cannot do activity face to face, or you cannot do activity that can just go to sit with a large group of people. So we need to introduce Zoom, WebEx, or whatever online platform that can consult. And of course, the effective or efficiency of those online platform will not make the consultant going easily or get as smooth as we expect. So we have done the pilot in the northeastern of Thailand. It consists of 7 provinces, Udon Thani, Suvarnabhumi, and so on. We have allowed 5 million population with 1.05 million children under age of 15. We have 2 regional hospitals, 8 general hospitals, 78 community hospitals, and 874 sub-district health promotion hospital. We provide this Child Shield as is a protection framework in order to help surveillance list, doing a risk assessment model. We do intervention with POH, and if the case become victim, we do a PMIRO, as I mentioned. And as the problem on the increasing lack of manpower, as we know, COVID-19 for some reason make the violence in the family increasing, and also many problem is introduced due to the economic situation and everything. So we try to change from this reactive or passive traditional child protection to proactive one. It's correct data is centralized data, it managed and gathering all information, and it's not just only from Ministry of Public Health. We mapping data from the other ministries, for example, Ministry of Labor, Ministry of Justice, Ministry of Interior, and so on, because we have to get into the family information. Sometimes we also get data from the Ministry of Education, because we believe that in school, teacher will be one of the best source that provide information to us. We also need to use a lot of system in order to connect those database. We use API and cloud technology. And as I mentioned earlier, it has to be for the Personal Data Protection Act. This is a regulation in Thai. And we also comply with the EU standard GDPR, General Data Regulation Protection. We use machine learning to analyze this data, and we create a risk assessment model that can identify which student in the system is at risk. And then we try to extend that risk. As I mentioned, it's important to know environment of the children, especially in their family, their home. So we get data from the local officer, and then we feed this data back to make the model even more accurate. And when we present this data into the application that accessible from the smart device, it's a smartphone, tablet, laptop, and everything, we design a data a platform that can be responsive and match to the model in the platform. And I also mentioned before that we have to design a platform not to be burdened. We try, as imagine you when you do a cell phone, it will be difficult to entry any data other than you do the drag and drop or have a tab. So we try to make it simple because many warranty officers are in the senior citizen generation, so they are not used to get into the high technology tools. So we try to make it simple and also easier for understand. Then we have all the social worker work on this evaluate this program and see if they have any problems in order to improve the usability of this platform. Then we do the list for the each individual group in order to let the caretaker or care manager do intervention. And then we inform the child or the parents through this application. So we can get more information. And same we ask the teacher or the friend at the school, because these are one of the things that can do mislead. Many times they are mislead information. The kid get bullied at school, but the caretaker thought that, oh, because the kid parents are separate, so they many times the case of the machine learning need to find out the root cause. So we try to gather information as much as possible in order to find the better result and more accurate. And this is how the idea of the concept model. When the child and family register or connect into the system, they enter the data pool, and then the machine learning will come with the risk assessment. If there are no risk detection, then they go back to the data pool. But if there are the risk detect, then the case manager will be notified, and the caretaker or the health worker will go to take care of the kid. They will go to see the parents and so on. But if they find out that, hey, the model is wrong, when they go to see the case, there are nothing wrong with the kid. So we go back and then we modify the model. That factor will be not significant anymore. But if the list is consumed, then I confirm, then we design and do the implementation on the intervention of the work plan. We send the staff and do the case analysis and get the more data. And then we try to solve. If it works, then that's good. But if it fails, the kid become victim, then we send to the Primero. It's another program that take care of the case. So this is a core concept of this. And this is happened during the COVID, where we use all the Zoom and device. And this is a model, as I just said earlier, we do the surveillance, we use the big data, we do the AI for the deep learning. And if we found that the kid is risk, we try to make sure that we get the enough information. The staff will be sent to the community and their household in order to collect more information to make sure that our program is, yes, they are the victim, or they are list, or they are no problem. If the kid is victim, we try to do all the intervention in order to make sure that they will not fall into the justice system, because the WHO already mentioned that if the kid fall into the justice system, they will leave something like a trauma to their experience, and then that the victim can become the predator and so on. They get used to bully, and then finally they will be the one that bully the other people. So we try to bring the kid back to the society as much as possible. So that's why our surveillance system is very important one. We don't want to move into this, and that's why the UNICEF provide us another Primero case management program. And as I mentioned earlier, it has to be GDPR or PDPA, anything that regarding to this information are very case sensitive, because we deal with the kid under 15. Sometimes it's most likely it's kid under 8 years old. So it has to be private, and data need to be very secure. And this is how the model and platform work. We divide into 3 groups: normal, risk, and violence or victim. We provide intervention for each. And this is a PLH program that we get from University of Ford, UK, and with the help of UNICEF and my faculty, Public Health Mahidol. we convert this program into electronic version and we make it into Thai style, and the data show that everything is getting better. The positive outcome, the parental depression is getting better, child behavior problem is getting better, and daily child, everything is getting positive. And you have to imagine this is done via Zoom or electronic platform, which is very difficult or much more difficult compared to the conventional face-to-face. So we get a very good positive result. However, there are negative effects because it take more time. I mean, if you imagine when you try to consult face-to-face or you go to the parents or guardian and then you work as in a group, it will be more effective than you try to teach online. But we successfully do it. Then this is a original one. We do everything on site, face to face. We try to teach how to be a good parents and solve the problem of their family in order to avoid kids getting abuse or violence. But as I mentioned, the online platform still get a very positive one. We get a positive result from the caretaker or staff. They say that their workload is getting better, and because of the machine learning, help them identify the problem easier. And this is an example of the platform that we convert into the digital. Sorry, it's in Thai, okay? And so this is a conclusion. We successfully, through the partnership, we have a lot of partnership, and we make this platform come through. We implement it, and we impress UNICEF. They say that Thailand is one of the first that can make the BSPH, the database. We prevent many cases that the kid almost get violence or get abused, and we come up with the idea how to mix the group of the parents from the worst until the best, and then we let them teach each other. We do a lot of online platform, and we can say that we are successfully done consulting using the online platform via Zoom and many things. And even many family are poor, we provide them with cell phone, internet, and we use the online platform, and it still work. And this is our future of the Child Shield. We try to get more information in order to make the data or machine learning more accurate and more useful. We try to connect or map with another ministry in order to establish the central information. So not just only they use for preventing violence or protecting child get violence, but also can use for any other case. And then we have to follow more security and ethical, because the more ministry we connect the data with, the security need to be more tight. We had a ransomware problem last year where some of the people try to hack into our database, but we luckily we can prevent it. And then we with data more connect from other ministry, we can do more intervention. We can solve the problem on parenting, separating, and blah blah more. And also we can increase coverage. We launched for 7 provinces in the northeastern of Thai. This year we launched for 15 more provinces, and we plan next year for the nationwide level. And this is my special thanks to Ministry of Public Health, former Inspector General PH team from Thailand and Oxford, and many staff, especially IT team from Thailand and UNICEF. So this is my presentation though. I just want to share that with the technology, it can help. You don't need to think that, hey, you need to make a really big thing for the IT or innovation, but small thing can improve as long as you can make it fit into the society. It can improve effectiveness and efficiency for the healthcare worker. And one thing that I always remind myself when I decide the IT, it not need to be the burden for the caretaker or the staff or officer, because many people say, hey, we already have IT, we already have technology, we have a lot of innovation, but they forget that many times they have to do two systems at the same time. They have to do simultaneously. Sometimes it's not completely electronic form. You still have to do paper-based. So this is what I proudly represent, that UNICEF is also very happy with us to make it successfully done. Thank you very much.
Thank you very much, Prof. Pechipong. Yeah, I remember one thing, just do a small things, but big impact. I never heard about how digital health works in child protection. Is very remarkable speech. And we still have one more speakers. Last but not least, we have Bapak Febi Dwi Rahmadi, SKM MPH, PhD. He is a lecturer in Global Health School of Medicine and Dentistry at Griffith University, Queensland, Australia. We already hear from Thailand, Philippines, Indonesia, and Miami, and we have the last one from Bapak Febi. The floor is yours.
Thank you, Mbak Loverina. It's a pleasure for me to be here, and it is also a privilege for me to learn from Prof. Fernanda, Prof. Elahe, Prof. Agustin, who is my, my lifetime mentor since I did my Bachelor of Public Health from University of Indonesia, and also Prof. Pechipong. So it's a pleasure for me to learn from you all. Okay, so please allow me to share my screen. So I think I can share my screen. Okay, can you hear my voice okay?
Yeah.
Okay.
Yeah, it's good.
Okay. I'm not sure which slide. Okay. You can see my slide, right?
Yeah.
Is it in a presentation mode or?
Oh.
No, okay.
Yeah.
I might have to.
To click the slideshow on the, yeah. Oh, not yet. But I think,
No, because I have two screens, so I think that's something that I need to. Okay, might have to. We're talking about digital, but now we are. Okay.
Some technical problems sometimes happen.
Yeah. So. Okay, can you see my screen, right? So it should be.
Oh yeah, finally.
Okay. Oh. Okay. All right. So what I'm going to deliver today. So I'm going to talk about some examples in Queensland about weight-based health and well-being resources. But first of all, I would like to put into context first, because as we all heard already from Prof. Elahe from US context, and we also have heard from Indonesians, Philippines, Thailand context, I would like to also put into context in Australia, where I currently live in. So first of all, in Australia, this is data back in 2018, but this is the latest that I can get. So you can actually see some of them, maybe you're familiar with TripAdvisor. So where a lot of actually 2.6 million, people use TripAdvisor. So you can also look at also mobile banking, LinkedIn users, and etc. Health Direct. So this is something that is also relevant to what you're talking tonight. 84% go online first for health informations. And also you look at text, Facebook users, and etc. So basically, Australians are already digitally connected. So this is before COVID-19, because this was 2018. And now is 2022. We can see a lot of things happening during COVID-19, which will then also expand in terms of digital connectivity of Australian here. So we can also look at this fact as well, which is most of 77% Australian would like their doctor to suggest health information websites. So this is where there is interaction between doctor and patients, and patients would like their doctor to provide information from website because they can then access from home. They can also, this is also similar to what I have explained before. So they use internet to research a health issue. So this can be positive and negative because there are quite a number of resources that you can actually find from Google, for instance, right? So that sometimes like people also call a Dr. Google because, like people sometimes they can make, like conclusions just based on internet. So this is something that can be also a challenge as well. But later on, I would like to share in the context of health and well-being, especially mental health. The federal government provide a website where people can see, the reputations of, different type of website related to mental health here in Australia. So they can choose which one they would like to use because there are quite a number of them. We can also see here, so this is also in the context of digital connectivity, older Australians, which is 69%, so they use internet to look up health information. So this is actually something quite, I think, quite significant as well in terms of digital connectivity. However, only a small portion of the populations manage to find an online health source they trust. So this is also a challenge. That's why Australian government through federal budget, so they also have some programs in the different state in Australia in order to make sure we improve our digital connectivity, especially for elder populations. So I'm not sure whether you can read this because it's quite blurry. If you look at this one, this is today and this is future. If you look at this one here, only 25 of youth facing, about 20. So 25% youth facing mental health, looking at for sick, looking at for help. Okay, so we can have a look at this one here from the Australian government digital health agency. So they would like to transform Australia to become more digital connected. So from different, looking at from a pregnancy, from a baby, childhood, youth, a young adult, adult and seniors, aged care, and also end of life as well. So this is something that to make sure that they can get help as appropriate as possible, as timely as possible, because digital connectivity can actually help in that context. Digital health in Australia, so there are actually mainly three products that they actually offer at the moment. So the first one is My Health Record, e-prescriptions, and telehealth. I think Professor Agustin to some extent has already covered this in her presentations, but I just would like to provide in the context of Australia. So this is what we are currently have already. So e-prescriptions has been used many times, like when I was also sick during COVID-19. So doctor can then we can have a telehealth and then and then prescriptions sent by email. So all we need to do is to show the email to pharmacists, and then pharmacists will, there's a barcode that the pharmacist will need to scan, and then we can just get the medications. Okay, so in the context of My Health Record, so this is something that I would like to spend a little bit more time in terms of explaining My Health Record. So this is one of the main platform that is currently Australian government, and this is also the blessing of COVID-19 as well, actually. So COVID-19 also, to some extent, also has brought some positive contributions in terms of digital connectivity. And we have this Australian Digital Health Agency. So this agency has been established back in 2016, actually. So few years before COVID-19. So this is a Commonwealth, which is federal government. But however, under the backdrop of COVID-19, digital has seen exponential growth, okay, in relation to, the relevance and also the importance, okay, making it more pertinent than ever for all Australian and healthcare providers. So as I said previously, so it's a blessing of COVID-19. So you can see this is my health record. So viewing discharge summaries, pathology results, medical imaging results, and etc. And later on, I would like to give you an example from my own health record. I'm going to also, of course, I'm going to blur some of them because that is my personal record, right? But this is, I just would like to give an example in the context of Queensland or Australia. So the data is, the national participation is actually quite high. So 90.1% of Australian has participated in my health record. And in the context of Queensland, so the state where I live, 91.2%. So we all have my own record, so including myself. So my health record provides access to information, so including vaccination, allergies, medical conditions, medications, and etc. Tests, scan results. Okay, so this is something that we can access and health provider can access as well. So the interesting part as well, because Australia is very concerned about data, security data, privacy data. That's why consumers, which is us, can control whether we want to like any specific information to be accessible by health provider or not. So we can actually manage this within our platform. Okay, I just give you an example. So this is how it looks like. So this is the landing page of my health record. So this is to give you an example, so I can see my name here. So the record home COVID-19 dashboard. So this is where COVID-19 happened. So they added one specific page for COVID-19. As you can see, this is vaccination. So you can see I got Pfizer 1, 2, 3. Documents, privacy access. So this is where if we click this one, so we can choose which data that we want to hide. Okay? We have our profile settings like emergency number, next of kin, address, and etc. So this is where we put our data. We can see here, for instance, if I do a scan, for instance. So this is Brisbane Diagnostics. So a couple maybe months back, I think I did a scan for my knee because I have problem with my ACL, my left ACL knee. So we can see the result here, and healthcare provider can also see this as well. Sorry, it's just covered there. So you can see discharge summary. So I haven't been hospitalized. Hopefully I don't need to be hospitalized. So you can discharge summaries, e-referrals, and etc. The pathology reports. You can also hear prescriptions. So any prescriptions that has been made by a doctor, you can also have a look at this dashboard as well. And any healthcare provider can also see this. But you can see this one here, manage access. So if you click this one here, because this is just a picture, you cannot do this. Manage access, you can hide. So you can actually hide. So which means only you can see. And of course the government, but not the healthcare provider. And you can also have a look at this one here. Also, this is the scanning and also the requester. So this is my doctor. And then the status and the action. So, and this is where we can also manage our access. So in the context of e-mental health, so as you can see, Australian, Queenslanders, they are quite digital connected. All right. And in the context of mental health and in Australia, this is the latest data that I have from ABS, Australia Bureau Statistic 2022, 1 in 5. So you can imagine 1 in 5 age 16 to 85 experience a mental health disorder. So it's a serious problem in Australia. So you can also see this one here, 8 million. So which is about 31.5 Australians reported had been diagnosed with long-term health conditions, and about 2.2 report mental health conditions, including depressions and anxiety. So therefore, there are quite a number of resources in the context of mental health and well-being. I'd like to give you an example, some of them. So e-mental health offers one of the greatest investor-safe opportunities for government and the communities in mental health, and clinically effective and huge cost savings. And also, especially in the context of the use of, a number of a platform, not only a website, but they also have applications. They also have some programs as well. I would like to give you some examples if time is allowing me to do so. So this is an example, Head to Health. Head to Health is by federal government. If you look at this one here, this is a very interesting interactive website. If I can give you an example, as I mentioned earlier, so can you see this one, the website? Yes, I think, right?
Yeah, sure.
But yeah, okay. So as I mentioned earlier, so we don't know which platform or which website is can be trusted, because if you go to Google, you can be buried with too much information basically. So here, so the federal government has already classified, so they actually check all the all resources in the context of mental health. So if you put anxiety, for instance, so anxiety, they have applications, program 18, and they also have 3 forums. They have phone, chat, and email. So if you can actually, if you want to go Beyond Blue website, so there are 41 websites in Australia that talk about anxiety. So you can actually choose. So this has been verified by the government. So the community can just click whichever they would like to click. Let's say if you want to click Beyond Blues, and then you will go to Beyond Blue website. They also have a page and etc. So if you click different keywords there, and they will, if you have depressions, so there will be different type of 26 website about depressions. Yeah, so that's all. Yeah, website about depressions. Yeah, so this is something that you can actually have in the context of helping the consumers or the people to choose which website or which resources they can use in the context of mental health and well-being. So back again to my presentation. So this is the Head to Health, which is federal government. And you can also, there is also a program that is initiated by state government. In this context, I would like to give you an example of Queensland government. So which is the program called Dear Mind. So Dear Mind is actually about remembering to take time for yourself, which is actually very important. This is for all of us. So we need to think about ourselves. So they have 6 building blocks. So get healthy, keep learning, show kindness, connect more, take notice, embrace natures. So if I think I can also give you an example of this. So this is an example of the website. So basically they have a deck. So build your deck here. So build your deck means you can actually evaluate yourself. Like for instance, if you want to get healthy. So the first one is like reduce your caffeine. So which is actually a lot of us drink coffee. And try outdoor exercise, stand up more, go screen free before bed. So this is also very important. Go to bed early. I don't think I can go to bed early tonight because this is already 11:40 p.m. in Australia. Get creative in the kitchen, etc. So if you click add to deck, so this can be viewed in our deck. So this is something that basically like a positive things that you can actually have in your daily life, which is very important for us to be healthy. So just to give you an example, so later on, because this is something you can also see from my slide. So get healthy. You can also show kindness. How we can show kindness, or like help a neighbor, think before you speak, and etc. Ask how are you. So this is something that to be kind, to other people, because for us to be healthy in terms of our mental health, so we need to be kind to other people. So which is actually very good. So. In the context of Griffith University, I just would like to, quick before I finish my presentation, to give you an example of how Griffith also put into their website in terms of mental health and well-being. So Griffith has 5 campuses, and we also have 1 digital campus. I think that this is also what was mentioned by Professor Elahi. So we also have a digital campus, and we already have online students. I think back in since 2016. So, however, now it becomes more blended. So we use a blended learning teaching as well. So our student has been, they have been using online platforms since before COVID-19. So all assessment, like in my course, all assessment is submitted online as well. The second assessment, like for instance, we have group presentations. So for face-to-face students, they do it face-to-face, which is offline, but then online students, they have to do it online. So we are using Blackboard platform, but in I think end of this year we'll be moving to Canvas. So at Griffith University, the same thing as well. So Online Health and Wellness Center is also part of our website, because we have online, we have international students, especially international students, they require more support. So there are a number of examples here. I'm not going to give you talk a little bit more here because of the time is a bit limited. But this is something that student can access, and we always have, we always advise student to go to a website first, but then we also have always, ready to support them by phone as well, just in case they need somebody to talk to. Okay, so so that's all basically. I would like to share my, some few examples from Queensland and Australia. So I would like to hear more, maybe if there is people would like to ask a little bit more, or maybe you would like to add something, so more than welcome to do so. Thank you so much. I would like to return back the microphone to Ibu Loveria. Thank you.
Okay, thank you, Pak Feby. We already hear 2 presentations from Prof. Pichipong and also Bapak Feby. So we open discussion right now. If all of you want to ask the question, please just write on the chat box or the question box. We will answer all of your questions. Or if you want to ask directly, just raise your hand and we will promote you as a panelist. So while we are waiting the question from all the participants, I have some question to Prof. Pichipong and also Bapak Feby. As we know, when we talk about digital health, most of us think about develop application. So in Indonesia, for an example, in primary healthcare, we have like a 40 or a 50 application in this in the primary healthcare, and the effectivity and then utilization is not quite good. And I remember Dr. Pichipong trying to you say about we need to simplify the technology, and maybe Bapak Feby and Prof. Pichipong can say and explain how we can make it simple, effective, and this application or the application that we already developed will be useful for all of us. Maybe Prof. Pichipong first. Would you like to?
Thank you very much. This is a good question. Let imagine you have 50 applications on your cell phone. When you, let's say, one application for each disease, right? Heart attack and many things. And if the people who use are not very good, let's say elderly people use it, they're going to keep scrolling your cell phone to find, hey, which app is going to find. And they may get heart attack and pass away before they've successfully find. So one thing for sure is it has to be simple. One just only couple apps is more than enough. But those apps need to be able to connect to the hospitals. Let's say when they should have some screening, personalized information, and connect to the main contact of the hospital for those people. When they have emergency, they just push a button or some screen that can directly point out what's wrong with them. Either they want to contact to the healthcare provider, emergency 911 or anything. Second, let's move to the part where the health worker or the case manager need to go to the countryside. If you have the application that is kind of complicated, you imagine you didn't bring laptop with you, notebook with you, you just bring cell phone. You go to the household in the village, doesn't have enough internet speed and so on. So it has to be simple, easy. The data need to be connect to the hospital. So that's only few information that need to be provided or fill in when they are they work in the field side. So this is a second part that I always keep in mind when I design the application. When I work with the Ministry of Public Health, I will tell them that it has to be simple, easy, and have to connect with information, can include data as much as possible. This is the key of my idea when I design implementation and so on. Thank you.
Thank you. Connect to the hospital is difficult. I just wondering, is it can we implement in Indonesia? Yeah, I just wondering how we can connect to the hospital. Bapak Feby, maybe would you like to add some?
Yes, just to add something from Australian context. So Australia only have one applications in the context of My Health Record. So that is that happens across different states, and that My Health Record is also attached to MyGov application. So all Australian or permanent residents will have MyGov account, which is attached to Medicare, which is our insurance, and also Centrelink. So like government support, like financial support, like if there is any disaster support, COVID-19 funding support. So everything is attached to that system. So I would say this is more about political commitment from people high level. They need to making it simple to their people. However, in the context of contact tracing, for instance, for COVID-19, previously we need to have contact tracing applications. Now we don't have to have that anymore. But every state, they have their own applications because they want to keep the record themselves. So that is where to show that for My Health Record, so we can have the same, we can agree that we only use one applications. However, in contact tracing, so every state, they have their own contact tracing applications. So if you go to a different state, you need to have applications for that particular states. But yeah, so I think it's about political commitment, how leaders, willing to make it simple to their citizen, which is actually very important. Communication is very important between different, high-level people, and making sure that we need to provide something that is very simple, effective, especially as Professor Pichitpang already mentioned, like how about, elderly population here in Australia. We also have people from, language other than English, for instance, right? So Australia is a very multicultural country, so they also have to think about that as well. Thank you.
Okay, thank you, Bapak Feby. So we're still waiting for other question from the participant. Is there any other question? Or maybe Prof. Ellie, would you like to share a little bit about the effectivity and utilization of digital health related to in primary healthcare maybe, or in the, yeah, your experience in Miami, maybe would you like to add some so we can learn from the other country? Would you like to share, Prof. Ali?
Was there a question for me?
Yeah, sorry, Prof. Ali. Yeah, we talk about the effectivity and also the utilization of digital health, because
Yes.
in Indonesia, for an example, when we talk about digital health, we think about develop new application. Maybe would you like to share, Prof. Bichipong and also Bapak Febi already shared their experience in their country. Would you like to add some?
So my expertise are only within education, and what I would be able to talk about that area would be more from a personal consumer perspective. Therefore, I reserve to speak within the level of what are my areas of expertise and practice.
Okay, thank you, Prof. Ali. Or maybe I think it's fine if you want to share your experience as a consumer, as a user in your country. Maybe is there any application or related to digital health, like how to maintain like, yeah, to maintain the health.
So again, since it's not from an expert perspective, I prefer to, because I know that in certain areas, I have every expertise of what happens in the country at every state and what are the levels, but not on the digital health records.
Okay, thank you, Prof. Ali. So I think the session is almost.
I think if I can share something about Laveria.
And I think we have one question, I hope.
Oh, okay.
Okay, before we share, would you like to maybe Prof. Bichipong and also Pak Febi, would you like to answer the question from Rias? How is the strategy to make the health provider adopt and adapt the system, and how is the government socialization to the community and response of the community about the system? Maybe would you like to answer that question, Prof. Bichipong?
Yeah, one thing you have to imagine, this is a tools when you have a digital health or you have the IT, it will be difficult for the people to change or adapt from their paper-based system. Let's say that we have, let's say, health literacy. We have people to try to educate people to make them understand, hey, what is the benefit of doing this? I have experience with many hospitals staff, they don't want to change from paper-based to unit-based.
Yeah.
They say that, hey, they will become, the workload will be double or even triple. They need to fill the form, because when you implement a new system, the system never be perfect, 100% perfect, right? There always be a patch, a bug to fix. So that with those things to adapt, they will many people try to against it. So we have to show them that the evidence by that, hey, if you do this, it will be easier, it will be better, you will be less burden, the system will help. Similar thing when we go to the community, we have to educate them. Hey, this will help you. You imagine you go to visit hospital, do body checkup. If it just only paper-based, then that's it. But if you put into the digital platform, then you can compare, let's say, your blood pressure from 6 years ago to up to now. The medicine that you take, it will be personalized medicine. It will be personalized health information. Then you can contact with your hospital, and then they can do intervention, especially regarding to your condition, and it will be much better. So we, other than developing the IT or platform, we prepare for those people for the health literacy, health education, in order to let the community understand. And once they understand, they will respond to the change. They will be easier to adapt into the new system. And I mean, we not luckily as Australia that has one application. We have many applications, and each application they have their own database. So that's why I told in the beginning that the health information exchange is very important. We need to make sure that they share information. Otherwise, it will be just only silo program.
Yeah. Okay. Thank you, Prof. Chipong. Bapak Feby, would you like to add some?
Yeah, in Australia, so in 2018, so they have published what they call Australian National Digital Health Strategy. So through this national strategy, so they they work with third-party provider to basically train healthcare providers in Australia. So, and if you go to their website, so they also have, like, for instance, Queensland, if you go to state Queensland, so they have healthcare providers that has been certified by this agency, which means if you go to these healthcare providers, your data will be integrated. So there are potentially, there will be some other, small like healthcare providers, like, or maybe private clinic, which is not integrated yet. However, in their website, you can actually choose, as a consumer, you can actually choose whether you actually want to connect your health record to the national platform or not. Okay, but as I mentioned earlier, so about 91% would like to connect their health data record to the national platform. So that's actually one thing. So they provide trainings for healthcare providers and also for consumers as well, especially for population at risks like young adult and also elderly populations. This is in the context of mental health and well-being. Something that we also need to provide as well, and this is also important, which is a cybersecurity training as well. So as was mentioned by Professor Pichitpong, right? So as we become digital connected, it means there is no secret anymore. So there's no, all data has been, it is easier for our data to be exposed into public. And this is also just happened in Australia. Optus, one of our biggest telephone provider in Australia, has already declared that their data has been breached, and so they've been attacked by a hacker. So including myself, so they contacted me so I can change my driving license for free. So they will pay for our driving license because I have to change my driving license because they stole my driving license. Details, so I can just go to Queensland Transport and they will replace my driving license. So, and they will have to pay. So, and this has happened also just now. So that's something that I would like to share with you. Thank you.
Thank you, Bapak Feby. And I think this event is about to come to the very end, and because it's almost 9 p.m. in Indonesia. So ladies and gentlemen, I hope this session and this webinar are informative and we can learn a lot from all the speakers. And I also want to say thank you very much for Professor Eli and Prof. Chipong, Ibu Agustin, and also Bapak Feby for your presentation. Very insightful. We learned a lot from you. But let me summarize this session. We already talked about the competency from the Philippines and digital health content from Indonesia and the requirement of digital health education from Miami. We also learned about the implementation of digital health from Thailand and also Australia. So to sum up, digital health school and program need to revise the curricula to better reflect the evolution of the field and address emerging public health challenges. I'm trying to pick up small bits from Professor Pichipong. We need to start from the small things, but we can make a big impact, and we need to simplify the technology. I will always remember that, so the technology will be more effective and more useful for the public health sector. So before we close our session, I would like to invite all speakers to give a closing statement, just a little bit related to digital health content. Maybe we can start from Prof. Ellie first. Would you like to answer?
I want to express my gratitude to the organizer, to Professor Augustine. I think it is, as you mentioned, learning little by little, being collaborative and learning from each other, with each other, that we would be able to conquer the new era of digital information. There are many opportunities ahead of us, and I'm eager and excited to work with all of the presenters here collaboratively, as well as anyone who listens to this webinar. I think it is our collective global efforts that would be for the best results for our global community. And thank you again.
Thank you, Prof. Ali. How about Prof. Pichipong? Would you like to make a closing statement, please?
Yes. First of all, I have to say thank you to today. Though I'm very happy to be here. Very lucky to be here. I should say that I learned a lot from you, and I believe that with the topic today, we all learn to share information and help collaborate together and make it better. From the COVID-19, we learned that digital health is one of the very important things that come from many sources, and we can use this to encourage people, get familiar with it, to do prevention, promotion, and protection. And with this, we will be able to survive and move to the next level of the healthcare. Thank you much.
Move to the next level of healthcare. I also remember that. How about Bapak Feby? Would you like to add some closing statement, please?
Okay, so I think this is also very important for us in terms of digital technology. I think 3 principles need to be fulfilled. So the first one is usable, useful, and used. So no matter how advanced your technology, if it is not useful, not usable, and nobody use it, so it won't make any impact. So maybe that's my closing ceremony. I also would like to say my sincere thank you so much for the organizer, and also for having me in this very important webinar. Thank you.
Okay, I remember useful and usable. We should remember that. So
three useful,
yeah?
usable, and used.
Oh yeah, usable and used. I'm missing the last one. And I would like to invite Ibu Agustin to present not the closing statement, but I think for closing the session, because for the chair of the Ibu.
Okay, thank you, Ibu Lofi. First of all, I would like to thank Professor Ellie, Professor Pichipong, Professor Jun, and Dr. Feby Dwi Rahmadi for joining our webinar this evening and this morning. So all your what you have shared with us are very inspired for all of us. So I believe we learn a lot then, and we can use what we heard today to enrich our content, curriculum content, as well as also to improve the way we deliver the content to our students. I know that the situation, especially in Indonesia, is very very tough. The variation between one area to another area is very big difference, big gap. But I believe that we have the same idealism to provide the best to our students, and we hope that the students, our graduates later on, will give their best to our community. So let's work together with the principle that no one will be left behind. As a long train, maybe Universitas Indonesia is the locomotive, but everyone will go together to reach the best future of our nation. So again, thank you so much for your contribution, all the speakers, Professor Ali, Professor Pichipong, Dr. Feby, who are still with us up to this time, and also Professor Jun. And thank you so much for all the participants. Hopefully this webinar will give some benefit, some useful information for all of you. Thank you, and maybe we can meet again in another forum discussing another important and interesting topic. Thank you. Good night. Good morning, everyone.
Good night, everyone. Good night, everyone and all participants. Before we close, I have some announcement for all participants to fill the attendance form. We will send all the certificate after you fill the attendance form. So don't forget to fill the attendance form. If you have any question or there's some trouble with the certificate, please do not hesitate to contact our secretariat, and also don't forget to follow our Instagram, because we talk about digital health, we'll also talk about media. So don't forget to follow our Instagram at IPTKMI, or you can subscribe YouTube IPTKMI. So on behalf of the committee, I would like to say thank you for all speakers and all participants for your participation. Thank you. Until we meet again, and perhaps we can meet in the next agenda from Indonesian Public Health Higher Education Network. Thank you, everyone. May all of you stay healthy. Thank you.
Thank you.
Good evening.
Thank you, everyone. Bye-bye.
Bye. Thank you.
Thank you, Prof. Agustin.
Thank you, Prof. Ellie. Bye. Bapak Ibu mohon izin kita end meeting ya. Terima kasih banyak.